Welcome to Heaven and Health Podcast, your trusted source for insightful conversations on health and real estate talks. I'm your host, Angel Polido. If this is the first time joining us, Heaven and Health Podcasts are designed to inform the public about different health matters and to give you an insight about anything concerning the land. Joining us in our today's episode is Dr. Chipewa. I hope you guys already know him. So today we'll be discussing about depression and anxiety. So stay there and be with us along the way. Welcome, doctor.
Thank you very much.
Hope you're doing great.
I am doing great. How are you?
I'm fine. So, focusing on our today's topic about anxiety and depression. Okay, first of all, let's break down by exploring in each topic. So, what is anxiety?
Great. So, anxiety disorders are a group of mental disorders which are characterized by excessive. So, those are keywords: excessive, disproportionate, and prolonged anxiety and fear, and there are related behavioral and physiological disturbances with associated impairment in functioning or subjective distress. In short, if someone has got fear, which is and is anxious, which is prolonged and disproportionate, and when that is causing distress or impairment in someone's function, we call that an anxiety disorder.
So, what are the most types of anxiety disorders that are prevalent in Malawian patients?
All right. Maybe I should just give you what we mean when we just, they are still fear and being anxious. So it's a normal process for a person to be anxious and to be afraid of something. So you are anxious when you are actually suspecting a potential threat, and that is normal to each and every person. And sometimes we are afraid. But when that is prolonged and when that is too much than would normally be, we call that a disorder. And so here in Malawi, and of course across worldwide, we've got a number of them. Actually, mostly we talk about 7. And the first being selective mutism. We've got separation anxiety disorder, specific phobia, panic disorder, agoraphobia, social anxiety disorder, and general anxiety disorder. But the main one is actually the panic disorder. Yeah.
So can you explain those in brief?
All right. So in brief, selective mutism is when somebody is silent in places that they are supposed to speak.
Like in public places?
So it would be in public places. I'll give an example. So someone is selectively mute, but they are selectively silent in places that are supposed to speak, despite speaking in other places. For example, you have here a child who is, let's say, 10 years old, and are able to talk freely at home. They're able to enjoy conversations at home. They can converse with anybody. But you take the same kid, you put them in a classroom, it's as if they are mute. They can't talk. So we call that selective mutism. You select the places where you talk.
Be silent.
Yes, and there's places where, But then it's actually a disorder when that causes impairment in your career. In a way. Sure.
So how do you think there's the difference between the normal worry and the anxiety disorder?
Like I said in the first place, normal worry is what everybody would have when they're anticipating a potential threat. But then this becomes an abnormal when it is, first of all, when it's excessive, when it's too much. You see, the cause for that worry is actually little than the amount of worry a person has. That's the first thing. So it's excessive. The second thing is disproportionate. So you have a small trigger. For example, you just being found in a public place or you just been found in a place where there might be scrutiny. Yes, you might have some anxiety, but when that is disproportionate, that is just too much.
Yes.
We call that, it's like disproportionate to the cause. We call that, we also anticipate that to be abnormal. And when it's actually prolonged, when that is happening for several days, and one of the hallmark period that we use as by the criteria that we use is actually 6 months. So by 6 months, when we see that these things are still occurring, then we know that this is abnormal.
What about if it happens like for 2 months or maybe a week, since other people are different in their mental capacity?
So now it also depends with other criteria that we use for a particular disorder. For example, we just talked about selective mutism.
Yes.
There are others like specific phobias, where some other people, they're just afraid of some things like snakes. They're afraid of heights, like just to fly, with
just seeing a bee or something like that.
Yes, others water, they're afraid with water, others are afraid with an injection, to have an injection. So we analyze those things. If that, for example, for specific phobias, if it occurs maybe in two months period, we'll still say you have a disorder. Yeah. So it depends. Great. So like I talked about selective, and then there's separation anxiety disorder. So in the separation anxiety disorder, somebody is very worried to be separated from either home or from major attachment figure. Like
the way we have been seeing other people going in secondary boarding schools?
Yes. So others who, at a particular age, for example, the kids, it would be understandable that they don't leave home and they don't want to be not to be attached from their parents, to be detached. But then you see someone who's 15-year-old or 20 years old, and they still are so afraid when they anticipate to be detached from a major attachment figure or from home. We call that abnormal. So that would be separation anxiety disorder. And then I talked about specific disorder, where specific phobias, where someone is just afraid of some specific things. For example, they'll be afraid of a snake, of water, of heights, and other things. And then there's a panic disorder, where a person just have this recurrent intense fear or worry, and then there's so many things that happens. Others have heart palpitations, others they menstruate, others they sweat. So that happens with the panic disorder, and the others like agoraphobia, social anxiety disorder, and general anxiety disorder.
So can you share an effective coping strategy or technologies you recommend for anxiety management?
Great. So when we are managing anxiety disorders, and of course some of other mental disorders, we approach management in 3 things. So we call this approach biopsychosocial approach. So biologically, we've got medications that we give. For example, we give what are called serotonin selective reuptake inhibitors. So
and those are.
So these are medications. For example, one of the examples is serotonin. So these medications, they actually inhibit the reuptake of transmitters called serotonin in the synaptic cleft. It's actually more
like that concerns the leaf action.
In a way. So for example, for you to have some emotion, you actually have to have the hormones. The hormones transmitted. But and then these drugs comes in to inhibit your organs to take these hormones that will cause you to actually have that worry. So when that is inhibited, you actually tend to be a more relaxed person. So biologically we give such medications.
Socially.
And then socially we call there's a psychologically. Okay, so I'll start with psychologically. With this approach that what we call cognitive behavior therapy. So you actually sit with the patient and you start to talk with them with their worry, to challenge their thought process. So that is cognitive behavior therapy. socially, you also engage with their parents sometimes or their family to actually tell them that they should understand this kind of a disease on the patient, that it's not the patient is not it's not an abnormal thing, that someone
Like
is actually
it's
sick.
something not normal,
Yes.
which is abnormal, yeah.
Yeah, it's abnormal, but then they need to cope up with the patient. Sometimes also we actually show them that they are not alone in this thing.
Yeah.
There are others who are suffering. So for other types of the disorders, for example, specific phobias, where someone is actually afraid of something, we do what is called systematic desensitization, where we want a person to actually get accustomed or to get used of the thing that they are afraid of, so that they are no longer afraid of. For example, if someone is afraid of a snake, we bring them, for example, in the first place, we bring them a picture of a snake, and then they tend to be so afraid. And then we tell them that it's normal. Then the next time we're going to, bring a dead snake, and then they will be afraid, but eventually they're going to get normal. And then later we're going to give them, to show them the little snake. So
Okay, like showing them the real snake. Okay, if I'm afraid of a lion, are you going to show me a lion?
Okay.
Like a lion. So you take people to the zoo or what?
Okay, so for the example that we've given here, a lion, that would be a far-fetched example, because most of the people are not exposed to lions.
Yeah, it's just an example for us.
But if that would be the case, what we'll do is, for example, in the first person, we'll take a picture of a lion. And then by just showing you the picture of the lion, then it'll be like a trigger. You'll be so afraid. And you'll be like, no, it's just a picture. Then, after talking to you, you're going to get used. You'll be okay. The next time, we may actually maybe get a video of a lion. And then you see that lion, you get so much afraid. We talk to you, you are okay. And next time, then we might actually take you to the zoo, to show you the new lion, and then we talk to you, and then you'll be okay. So systematically, we actually desensitizing.
Don't you think like making these people be used to these things? Don't you think that they can also lead to? Don't you think that it can also endanger their lives? Like they are like showing them the actual snake, and I'm used to the snake now. Being a child or being someone else, don't you think that I can start praying with the snake?
You can start it?
Like praying or doing something like naughty.
Not necessarily. Like I've told you that there are several things that these people are afraid of. So then it may not only be the snake. But at the end of the day, what we want to achieve is that this person should not be too afraid of something that their normal life is affected. Because this too much fear, it affects their functioning, their normal functioning, their day-to-day activity functioning.
Yeah.
So what we want is to make sure that we have this fear away. And by taking this fear away, it does not mean that now these people have so much freedom to play with these dangerous animals. No.
Okay.
No, yeah, sure. That's how it goes.
So how do you incorporate relaxation method like deep breathing or mediation into anxiety treatment?
We actually do incorporate. We do incorporate. It's part of the therapy when somebody is too anxious. For example, in general anxiety disorders, where people are just anxious for nothing. So and panic disorders. So we actually have those times where we are doing relaxation exercises, so that a person can actually now become. Yeah.
So now looking at the depression part, what is depression exactly?
Right. So depression, when we're talking it to be a disorder, I'll actually tell you this. You and me and just everybody else, and no person fluctuates in their mood. So today you'll be happy, tomorrow you'll be excited. The other day you're sad.
Yeah.
And so the trend of our mood does fluctuate. But if this becomes a sickness or a problem when these things are happening. First of all, when you have actually symptoms, in which one of them is low mood, so you've got persistent low mood. Your mood is low for quite a long period of time, at least 2 weeks.
What do you actually mean, like low mood?
All right. So like I've told you that there's a mood where you say this one is happy,
And
this
the
one is
other one is
hyper
sad.
excited, and then there's a mood where somebody is
Sad.
feeling sad, feeling down.
So the low mood is where a person is feeling very, very much sad.
Yes, when the person is feeling down. So there's an element you feeling sad, just you're down. You are not, you're not
feeling
excited.
normal. Yeah.
Yes. So when that is going on for at least 2 weeks, we take note of that. And also, we might have what is called anhedonia. For example, if there are some other things that used to excite you in the past, you were excited with football, you were excited with hanging out with friends, you were excited with maybe movies, but for a period of 2 weeks, these things no longer excite you, then also we suspect that you might be having depression. And then there are other symptoms which are there. There have to be actually 5 symptoms. So some of them will be fatigability. You're just tired. You haven't worked, you haven't done anything, but you just feel tired. And also there's what's called hyperinsomnia or hyperinsomnia, where a person has got an excessive need for sleep. They are just sleeping. They'll be sleeping the whole day, or sometimes they like sleep. So other symptoms would be feeling of unworthiness. You just feel you are not worthy. Others, they just feel guilty for nothing. They haven't committed anything, but they feel guilty. And sometimes it gets worse to suicidal thoughts. Others thinking of actually, dying, of removing their life. So when these things are happening to a person in a period of 2 weeks or more, then we say you've got depression.
Wow.
Yeah.
So how do cultural beliefs and stigma impact depression diagnosis and treatment in Malawi?
So cultural dynamics do really influence the diagnosis and treatment. In the first thing, Malawians are not really accustomed to most of these mental disorders. If someone is really depressed that they're sick, others would be sarcastic about that. They'll be like, they will not see it as really a sickness that need medical attention.
Yeah.
You see? And we have people, these things, people prolonging until others committing suicide. So the major impact is that we have got late presentation in the hospital or no presentation at all because of the cultural dynamics in Malawi. And because of that, we don't, tend to diagnose at a good stage, yes, at an earlier stage where we can initiate medications for this to get better. Yeah.
So are there any myths?
Not so much myths. I think a few, of course, where people believe that as a Malawian, a local Malawian, you cannot really have depression, for example, as a mental disorder.
As a result, you may think that someone is preaching you or something like that.
Of course. Others think these are diseases that maybe people who are well-to-do, they're wealthy, and maybe even wealthy nations that they do experience are not here in Malawi, but we actually see this in Malawi. Even poor people, they do get some of these mental disorders. So that's a myth, I think, across the country.
What treatment approaches have you found most effective for depression in your patients?
So it's the same approach that we use also in anxiety disorders, what we call biopsychosocial approach. So biologically, we want to administer medications which are mood stabilizers. These are medications that will stabilize your mood, will make you calm. So that's the first kind of treatment that we do. We give them mood stabilizers. And the other, psychologically, we want to have a cognitive behavior therapy where we want to sit down with somebody who is depressed and then challenge their thought process to say, to hear them out. What are their fears? What are things that, they make them to be so sad? And then we try to tackle that, to challenge. So it's called cognitive behavior therapy. Sometimes we want to also counsel the guardians to be able to live with that patient well.
Yeah, to have more time with him or her.
Yes, more time with them because they need family. And the other thing that we do manage risk management. So these patients tend to have risk to themselves, and risk to others, sometimes to objects. For example, somebody who is depressed, sometimes they just want to take their lives away.
Yeah.
And that is a risk to themselves. So we address that. We also address risk to, on the same risk to themselves. You see others, they just want to abuse drugs. They are so depressed, they just want to go out there, drink alcohol. Others just want to take some of these drugs, like cocaine and others. Others just want to sleep with somebody.
More like sleeping or doing something bad.
Yes, doing something bad just to relieve themselves. So we address those risks. Yeah. So risk management is part of the.
So most of the dangerous things that these people do is like raping and stealing or doing something bad outside there.
Others, they don't even go rape, but they get raped.
Oh.
Yeah. Or others, they will just want to go. Sometimes it's deliberate. They just want somebody to just
do something bad.
With them. Just sleep with them, for example, so that they can actually maybe they'll feel good afterwards. So all these risks we try to address them.
Okay, so what role do you think the community can play as one way of recovering from depression?
So the community has got a great deal in helping the recovery of these patients. The first thing is that the community must admit that we have patients amongst us in Malawi, either in urban or rural areas that are sick of these mental disorders, for example, of depression. And when they suspect that somebody is being abnormal in their mood, like I've said, when their mood is depressed for quite a long period of time, when they know these abnormalities, the community is duty bound to take these patients to the hospital where appropriate treatment can be initiated on this patient.
Yeah. Now, combining depression and anxiety, how do you address co-occurring depression and anxiety in your patients?
So actually, these they do occur concurrently. Most of these, so the depression would be concurrent with substance and abuse disorders, and also with anxiety disorders. So how we do manage this, we tend to treat all these individually. So we target anxiety disorder in the patient. After that, we also, we go to target the depression that they have, and also we go to target other comorbidities that they may have. Normally, when you are targeting one, the others they tend to get better as well. Yeah. So we have a holistic approach where we tend to approach each and everything in the patient.
What are some barriers to seeking mental health care for depression and anxiety in Malawi?
So like I said, here in Malawi, the first problem that we have is people do not admit that we have this as a real problem in our midst. So that is the first challenge, that's the first barrier, that people do not admit that we have these conditions. And the other barrier is late presentation. So if people don't admit, then they don't come to the hospital early. So with late presentation, we have patients, at advanced stages, where yes, we initiate treatment, but things that would have avoided sometimes they tend to happen. So the major barrier is lack of admitting on the side of Malawians and late presentation in the hospital.
Haven't you
and also some myths, of course, which men, they say because you are a man you cannot be depressed, which is not true. Men are getting a lot of depression, and I think if you saw the recent publication of the police suicide cases, men were actually high in numbers because we have this, myth that we as men
are not depressed.
We are not depressed, when in fact we are depressed. So these are some of the barriers that we need to take out from our society.
So haven't you ever thought of raising awareness to get rid of this?
That is a great initiative we've always been thinking about. us in the medical space. And I should appreciate other cadres, people who are already going ahead to spearhead this awareness, and it's happening. Only that it's not happening at a scale which is really meeting the need out there. I think partly because of the funding, there's not much funding for this awareness. You know, for people to travel around, they need transportation. You know, and they also need food when they are moving around. So I think partly funding has not been enough for awareness to happen. But yeah, there's a great need for awareness in the country.
Okay, so are there any local resources for or support groups for supporting people who have depression and anxiety?
Come again?
Are there any local resources or support groups for individuals struggling with anxiety and depression?
Yes, there are so many local interventions. The first thing is, hospitals. For example, I work at Queen Elizabeth Central Hospital, and they've got actually a special department, psychiatric department, only for the patients who have got psychiatric conditions.
Yeah.
So they go there. And we've got also in the management, we initiate other groupings, what we call anonymous groups. So, for example, even patients that have got alcohol disorders, they meet with others also who are having the same disorder, but actually they are recovering, to learn from each other how the recovery process is happening. So we have those help groups initiated by our management approach, and we've also got the hospitals which are there. And here in Malawi, we've got actually a major hospital, if you know, which is dedicated special to treat
people under depression and anxiety,
or actually all psychiatric conditions, and that is Somba Mental Hospital.
Yeah.
It's actually a great tertiary hospital, and a lot of patients there. Others they get well.
Yeah.
Only that people just think that
they are not people. What?
You see, but yeah, people really get helped. They go there, they receive the medication, they receive the care, and then they get back. They get out of the hospital.
Yeah. So before I conclude with anything, you said earlier on that men are the most people who are facing depression.
Yes.
What do you think are the most causes?
All right. So, causes are actually biopsychosocial as well. So biologically, there are other people who are more susceptible to depression. Yeah. And that will lead to suicide. So others, it lands in their family. It's genetic. And other causes are psychological. For example, stressful events, events like divorce, for example.
Yep.
Even the loss of loved ones, and economic problems. Most of these affect men. Men are the ones that are going out there to source money, and are the ones that they need to, the whole family looks up to them, even the wife. So men, are facing a lot of these issues, and sometimes they get overwhelmed. And also with what we've just talked about, they don't seek medical care. Sometimes they tend to just, commit suicide.
Yeah.
Yeah.
So you as a man, have you ever felt this before?
Well, as a man, obviously, there have been a place where I've been, my mood has been low.
Yeah.
I've been depressed. Yeah, I've been depressed before, and I think my major occurrence of that was when I was in college. So when I was in college, really.
And which is the college?
That is when I was at, now it's the Kuwait Kamuzu University of Health Sciences, College of Medicine.
Yep.
When I was at College of Medicine, the Senate exam didn't go well. And I'm telling you, all these things that we're talking about, the low mood, the anhedonia, you not being interested in things that excite you, was there in me for actually a period of more than 2 weeks. So, and I was just sleeping at home, So that for me, it actually happened. And I see that happen to a lot of other people.
Yeah.
In, of course, most especially in medical school, when you're doing the program that I was doing, medicine and surgery, and you fail an exam, or you don't do well in the exam, you tend to have this. And even with just relationships, you were so head over heels with a certain girl, in love and buying all these things.
Yeah.
And
And then
then
turns you down.
She says, I'm no longer interested in you. People go in depression.
Yeah.
And others actually go, as far as taking away their lives. And this is happening, in our society. So for me, it never happened. Sure.
Okay, do you have any few remarks before you conclude your thing?
I think my few remarks is just to tell people out there that mental disorders are real, and it's high time that we admit when we feel something unusual happening to us.
We should take it very serious.
We should take it very serious, and also seek medical attention. When we see this happen to us, let's seek medical attention. When we see this happen to our friends and families, let's also, try to approach them and take them to a hospital where they can be initiated on the proper care.
Yeah.
Sure.
Thank you very much.
I appreciate as well. Thank you.
Welcome. This marks the end of our today's episode, and this is how Dr. Pasco has given us an insight on anxiety and depression. So we need to take a very good care of ourselves so that we shouldn't be depressed. And whenever we feel depressed and anxiety, we need to seek the right people to guide us. Thank you very much.